Okay, good afternoon, everybody to the east of us. We're here in Ottawa, and good morning to everybody further west. My name is Vanessa Poliquin, and I'm here in Ottawa at the SOGC offices with some members of the communications team, Eric and Danielle, and they'll be manning the technical aspects of this webinar. So before we begin, I just have a few housekeeping slides to read. Sorry, I'm just trying to move forward in the slides here. There we go. So all participants have been muted to ensure optimal audio quality. If you want to look at things in a full screen view, you use a button that looks like 4 diverging arrows on the top right-hand side of your presentation slide or your presentation screen. If you're having any audio difficulties, please let us know using the chat window at the bottom left of your screen. And it's only visible if you're not in full screen mode. Danielle and Eric will try to rectify things if we're having any problems. A recording of the presentation will be made available to all participants following this session. So how to participate? If you have any questions, you can submit them at any time using the chat box on the bottom left of your screen. Again, this is only visible if you're not in the full screen mode. We're going to have questions at the end of the presentation during a 15-minute question and answer period. And if we run into time limitations and that prevents us from answering all questions, we will provide answers by email following the webinar. Is everything looking good so far, Danielle and Eric?
We're just troubleshooting a couple of audio static issues. Maybe move the mic a little bit closer and we'll talk a little bit about it.
Okay, we'll keep going, and if the audio issues are still a problem, just continue to let us know. So I have no disclosures. And here we go. Thanks for joining us this afternoon. I think that you're going to find that 2018, this way, is everything okay?
Some listeners that are having some audio issues.
Okay. So we're still just working out some audio issues, everybody. Apologies. Can you guys hear it okay? Okay, so we'll keep going. So I think you guys will find that this presentation is very topical. 2018 is undoubtedly going to be one of the most exciting years for immunization in pregnancy that we've seen since the pandemic influenza vaccine was rolled out during the 2009 H1N1 pandemic. The National Advisory Committee on Immunization, NACI, has put out an updated statement on Tdap in pregnancy and is also updating the chapter in the Canadian Immunization Guide related to pregnancy and breastfeeding. As well, the updated SOGC guidelines on immunization in pregnancy are anticipated to be published in the next month's issue. So congratulations for choosing this webinar. It'll put you at the front of the pack for implementing these new guidelines. The focus of this webinar is to go over the what, who, how, and why of delivering the Tdap vaccine during pregnancy. Tdap refers to the 2 vaccines available in Canada for adults that contain tetanus toxoid, reduced diphtheria toxoid, and reduced acellular pertussis antigens. We'll touch on what clinical disease we are trying to prevent through vaccinating with Tdap during pregnancy, who should be vaccinated, how and when to provide the vaccine during pregnancy, and why. What's the rationale for this intervention? In the spotlight for this afternoon's discussion is the bacteria Bordetella pertussis. The clinical disease has been recognized for centuries, and there's a specific word for the clinical disease caused by this bacteria in almost every European language. All the names derive from the characteristic cough associated with the disease manifested by pertussis in young infants and young children. But what is often understated about pertussis is the potential severity of the infection, especially among young infants. Pertussis is one of the top 10 causes of childhood mortality worldwide, accounting for close to 300,000 pediatric deaths per year globally. And very young infants, less than 4 months, are the most severely affected, bearing the number of hospital admissions and death related to pertussis. As you can see on the top graph, following the institution of the whole-cell pertussis vaccine in 1943, the incidence of pertussis dropped dramatically from 156 cases per 100,000 to a nadir of 2 per 100,000 in the early 2000s. Presently, the epidemiology of pertussis follows a cyclic course with peaks every 2 to 5 years. This cyclic activity can be sporadic and it can vary by region. In 2012, an important rise in the incidence of pertussis was noted. As you can see in the bottom graph, the youngest infants, who are represented in gray, shouldered the largest burden of incident cases with a rate of 72 cases per 100,000 infants less than 4 months. There were 3 cases of infant deaths in otherwise healthy infants attributed to this particular pertussis outbreak. If I were to superimpose the graph of hospitalizations from pertussis here, it would look almost identical, with the youngest infants again shouldering the largest burden of morbidity related to the pertussis outbreak. The increase in incidence of pertussis was not unique to Canada. In fact, it was perceived earlier in California, Great Britain, and other Western countries. So what causes this cyclicity despite childhood vaccination against pertussis? Well, unlike certain vaccines such as MMR, a single vaccine against pertussis is lifelong immunity. We know from the APERT trials that were conducted prior to the rollout of the adolescent and adult booster, antibodies to a variety of pertussis antigens wane with time. As you can see in the graph on the left, antibody levels began to decline after 2 years, but remain quantifiable for somewhere between 2 in the individual. It's important to note that we don't have a serologic correlate for immunity, meaning that we don't know the level of pertussis antibody above which there's clinical evidence of protection from disease. But we do know from a 2014 study considering 2 cohorts of women, one from BC and one from Nova Scotia, they found that at 2 different time points, one before the institution of the adolescent booster and one following, about 50 to 60% of pregnant women had undetectable levels of pertussis antibodies, and that's represented by the dark blue in the graph on the right. In Canada, we have 2 formulations of the adult pertussis vaccine available. Both contain multiple pertussis antigens, as well as diphtheria antigen and tetanus antigen. Given the waning immunity to pertussis over time, NACI recommends that every effort should be made that every adult gets at least 1 dose of a pertussis-containing vaccine. But despite this recommendation, according to a 2014 survey of Canadians, only about 9% of Canadians report receiving a pertussis vaccine after their 18th birthday. Because immunity to pertussis wanes with time, adult infections are a lot more common than we think. Moreover, adult pertussis infections are less likely to be recognized, detected, and reported because they may have a more atypical presentation, and the general clinical suspicion for pertussis is less among adults. For individual infant infections, household contacts, most commonly one of the parents, are the most common source of infection. Given that adult vaccines are available, that adult immunity wanes with time, and that household members are the most common source of infection for an individual infant, a cocoon strategy has been proposed. In this strategy, a booster dose of Tdap is given to anyone who is going to be a household contact of a newborn infant. In fact, this strategy was recommended in multiple countries in 2006, including Australia, France, Germany, Austria, and the United States. However, a Canadian study using epidemiologic data from 2005 to 2009 calculated the number needed to vaccinate for the cocoon strategy, and the numbers are listed in the above table. While this isn't a formal economic assessment, it does give you an idea of the cost effectiveness of this strategy, which is low according to this Canadian study. So moving on to the strategy of maternal immunization now. We've known about the potential benefits of maternal immunization against pertussis for the newborn for over 50 years, really since the first half of the 20th century, when it was recognized that infants born to women who had had pertussis during pregnancy were relatively protected compared to other infants. At present, we have over 20 studies that demonstrate that transplacental transfer of IgG occurs after maternal vaccination against pertussis during pregnancy. While all studies have evidence of rapidly waning infant antibodies within the first 2 months of birth, antibody levels for infants whose mothers received Tdap during pregnancy continued to be higher than those of controls until the infants received their own primary Tdap series. With the transplacental passage of antibodies, a maternal booster vaccination effectively protects the infant in 2 ways. First, by reducing the chance that the mother will be a source of infection for her child, and second, by providing the infant with some immunity until he or she can start their own vaccine series. Population-based data from Britain and California have demonstrated that this is truly an effective strategy with clinically significant impact. The data here is a retrospective study using population registry data from Britain comparing the rates of pertussis in infants less than 3 months for infants whose mothers did and did not receive Tdap during pregnancy. As you can see, depending on the timing of Tdap administration, the effectiveness of the vaccine for preventing pertussis in infants less than 3 months was up to 91%. This vaccine effectiveness seemed to be maintained even when Tdap was administered as soon as 7 days prior to delivery. Further evidence for maternal Tdap vaccination as a superior strategy to postpartum vaccination comes from the Kaiser Permanente Health Network in California, where they undertook a retrospective study of over 74,000 women. In this study, they compared the incidence of pertussis in infants less than 12 months for women who had received Tdap antepartum compared to postpartum. Vaccine effectiveness for antepartum vaccination relative to postpartum vaccination was calculated to be 85%. If we take a bird's eye view at the available literature, you can see that there is a good quality of level 2 evidence, so high quality retrospective studies, and these are represented in yellow on this graph. And these demonstrate that the administration of Tdap at a very broad interval through pregnancy can prevent pertussis infection, hospitalization, and death in young infants. A number of studies have also considered the optimal time to administer Tdap in pregnancy, with the endpoint of the highest level of pertussis antibodies with the highest avidity in the neonate as the outcome. The vast majority of studies have demonstrated that the vaccine is more immunogenic when provided earlier in gestation, but after 13 weeks. The study presented above considered 62 samples of umbilical cord blood, 53 from women immunized with Tdap at various time points during pregnancy, and 9 from unimmunized women. They found that the concentration and avidity of IgG to pertussis antigen were significantly higher for women immunized between 27 and 30 plus 6 weeks gestation. Another study considered administration of Tdap in the 2nd trimester, and they identified that the 2nd trimester was not inferior to the 3rd trimester. The graph to the right of the slide demonstrates that the efficacy of a number of time points is comparably superior to either no vaccination or vaccination less than 15 days prior to delivery, which are represented by the pink and blue lines that are significantly separated from the cluster of colorful lines representing the time points earlier in gestation. The findings of these studies can be briefly summarized by the conclusion that the most important factor in timing Tdap administration during pregnancy is to provide it several weeks remote from delivery. The benefit of multiple earlier time points in pregnancy being comparable is that it allows for a good deal of flexibility to the clinician and to the patient to choose a time for vaccine delivery that makes the most sense in the given model of obstetrical care. Safety data for the use of Tdap in pregnancy has been reviewed thoroughly by NACI. Data was reviewed from several sources, including clinical trials, cohort studies, as well as through passive surveillance. Passive surveillance has been ongoing in a number of jurisdictions, and pooled data represents several 100,000 doses of Tdap being given in pregnancy. Together, there are no signals of adverse effects for the fetus or newborn. Some recent data has emerged from a single study of passive surveillance data suggesting possibly an increased risk of chorioamnionitis or postpartum hemorrhage if a pregnant woman was immunized with Tdap during pregnancy. But these estimates are small from a single source and conflicting with previous reports. Moreover, it's important to remember that an important limitation of statistical analysis is chance identification of statistically significant differences approximately 5% of the time if a number of comparisons are made in parallel. The volume of data on the safety of administering Tdap in pregnancy is considerable. On the far right of the slide, you can see the number of women included in each study, and the figures for many of these studies are large. There are 3 studies that provide grade 1 evidence for the safety of this vaccine during pregnancy, and there is an abundance of large studies that provide level 2 evidence for the safety of Tdap during pregnancy. So the level 1 studies are in green and the level 2 studies are in yellow. Another concept to be aware of with maternal Tdap administration is the concept of immune blunting. 5 RTs have measured the immunologic response in infants following Tdap administration, so that's their own primary series. In all trials, antibody levels against pertussis antigens were lower in infants whose mothers received Tdap in the 3rd trimester of pregnancy compared to those of the control group. However, in the majority of the reviewed RCTs and observational studies, the differences in antibody levels disappeared after the receipt of the 4th Tdap booster, which was at 15 months. The clinical impact of these findings has not been assessed in the literature because the numbers needed to include in studies to assess the clinical impact of these small differences in antibody levels following primary vaccine series would be impossibly large. Given the lack of long-term data and the lack of serologic correlates for immunity, the relevance of these findings, given existing programs, remains unknown. Moreover, what this will likely translate to, with widespread maternal Tdap administration, is higher antibody levels in very young infants who are at the highest risk of serious outcomes from pertussis, and potentially lower antibody levels that may very well still be above a threshold of protection in older infants who are less likely to have severe outcomes related to pertussis. In light of all the evidence that we've discussed up to this point in the presentation, the NACI recommendations have changed substantially since 2014. The 2014 recommendation was published just prior to the population-based data out of the UK becoming available, and at that time it was felt that there was insufficient evidence to recommend universal vaccination. The 2014 recommendations certainly supported Tdap administration in pregnancy in the case of an outbreak or if a pregnant woman had not received her adult booster shot. However, the 2018 recommendation is largely simplified. It now recommends universal vaccination in each pregnancy, regardless of vaccination history. In addition to the biologic effect of maternal immunization and the population data supporting its efficacy in preventing pertussis in very young infants, additional rationale for the change in recommendation also hinges on logistics. Outbreaks of pertussis are sporadic and difficult to predict. As such, relying on identification of an outbreak to mobilize reactive vaccination campaigns was felt to be inefficient. The SOGC Immunization in Pregnancy Guidelines have been revised and are due to be published next month. The recommendation will be that all pregnant women should be offered the diphtheria, tetanus, toxoid, and acellular pertussis vaccine during the 2nd or 3rd trimester, preferably between 21 and 32 weeks gestation, regardless of their immunization history. In terms of guidance for when specifically to administer the vaccine during pregnancy, it's important to keep in mind that the time frame for safe administration of this vaccine and the time frame for effectiveness of this vaccine are both wide. NACI has suggested an interval between 27 and 32 weeks gestation, and the SOGC has opted for an ideal interval that is a little broader. The broader interval was selected in the SOGC guidelines to allow for the reality of prenatal care, reliance on opportunistic prenatal care for certain patient populations, and the potential for preterm delivery. The evidence suggests that there is considerable flexibility for when Tdap can or should be administered, and as such, practicality can be a key driver in terms of when it should be given. The most important factor is that there should be sufficient time between vaccine administration and delivery to allow for the production of antibodies and their transfer across the placenta. As such, it's important to emphasize trying to administer the vaccine several weeks before delivery. So it would be naive to think that a new recommendation for universal immunization in pregnancy will be rolled out seamlessly, especially if we consider our track record for the administration of other vaccinations during pregnancy, for instance, the seasonal influenza vaccine. Coverage for the influenza vaccine remains low. In fact, we estimate that fewer than 1 in 5 pregnant women in Canada is actually getting the seasonal influenza vaccine. We're aware that there are numerous barriers to vaccination during pregnancy, and to discuss them thoroughly would be a presentation unto itself. And maybe the SOGC will invite me back at a later time point to talk about that. But suffice to say that if we look at the top motivators for pregnant women to be vaccinated during pregnancy, the importance of a physician recommendation and protection of the fetus or the infant cannot be understated. As such, integration of Tdap into routine prenatal care should start with a recommendation from the prenatal care provider and focus on the benefits for the infant. Some prenatal care providers are going to be in a position to offer this vaccine directly in clinic, and others will not be able to offer the vaccine in a point-of-care setting. We can't underestimate the value of a strong recommendation for vaccination by a prenatal care provider, given that a number of studies have found it to be the most important motivator for vaccination during pregnancy. The CDC has put out a brief handout for physicians suggesting strategies on how to make a strong vaccine recommendation during pregnancy, and these can be accessed through the URL at the bottom of the slide. The key steps outlined by the CDC include beginning each referral with a vaccine recommendation that includes information on why the vaccine is beneficial and safe. Next, provide information on where and how patients can get the information, and that'll be specific to each prenatal care site. 3, consider writing a patient-specific prescription. Again, that'll depend on your site's strategy for immunization. Anticipate questions. Number 5, I think, is the most important. Re-emphasize that just because you don't stock the vaccine does not mean that it is not important. And finally, have a plan for how to handle questions from other providers who have concerns about vaccinating pregnant women. To assist in integrating the new recommendations, the SOGC and the members of the ID committee, specifically Dr. Eliana Castillo from Calgary, have developed a question and answer sheet that will be available on the SOGC website shortly, and it will be sent out directly to all registered participants. Before leaving the topic of the role of the prenatal care provider with respect to vaccinations in pregnancy, it's just worth noting that in Canada, we have limited ability to survey the uptake of vaccines during pregnancy on a national scale. And certainly in some jurisdictions, surveillance is improving through the use of provincial immunization and perinatal registries, but a registry is only as good as the data that's put in. So it's important to make sure that if you're delivering a vaccine in your clinic, whether it be for a pregnant woman or otherwise, to properly record the vaccine administration, whether it be through accurate billing or other, however your registry gets populated. And this helps epidemiologists around the country to make accurate determinations of vaccine coverage among pregnant women and also survey for any signal of adverse events. That brings us to the end of the presentation. I hope that what's been presented has accomplished our basic objectives. In the briefest of summaries, Tdap is recommended for all pregnant women in the 2nd or 3rd trimester, regardless of their vaccine history, in order to protect young infants from pertussis until the time that they can be vaccinated themselves. I appreciate integrating the universal practice will not be easy, and the approach for how will differ for every prenatal care provider. I certainly hope that if you've had success integrating maternal vaccination into your practice already, you might feel comfortable sharing your strategies with the group that is live here on the webcast today. Thanks again for being part of this webcast learning opportunity, and thank you for all the support staff here at the SOGC for looking after all sticks and the technology and my lunch, which is next. It's been a pleasure to speak to you this afternoon, and I would welcome any questions. Okay, so one of the questions is, can I show the link to the last slide again? I sure can. That should be popping up on people's screens. Okay. If a patient has 2 pregnancies within 1.5 years, is Tdap required for both pregnancies? That's a good question that has not been defined in the literature specifically. However, we do have safety data from outbreak situations where healthcare providers have received a tetanus-containing vaccine and then a Tdap vaccine in intervals shorter than 2 years, and that was an observational study and suggested that it is safe to give it at less than 2-year intervals. But in terms of additional efficacy of that booster at 2 years, I don't think we have the data to weigh either way on it. However, the APERT trial that I posted earlier showed that antibodies start to wane considerably at the 2-year mark. So once you're getting close to the 2-year mark, for sure, and according to our current recommend, it would be for every pregnancy, regardless of the timing interval. Okay. Next question. Is there a recommendation if a pregnant woman has received Tdap vaccine early in the first trimester? Should it be given again at the suggested time frame? Again, we don't have clear evidence as to what to do in this situation. I think that once it's been given in that particular pregnancy, it's not necessary to repeat in the 2nd or 3rd trimester at this point in time. Do you know if patients will have to pay for the vaccine? That's going to depend on your province. So what happens is that at the national scale, NACI produces national recommendations, and then those are taken to the provinces, who will consider whether they will adjust their provincial coverage or not. So currently, in the vast majority of provinces and territories in Canada, 1 adult booster of Tdap is covered. Some territories, for instance, the Northwest Territories, it's covered every 10 years. So right now, it appears that there's coverage in many provinces for 1 adult booster. And now that the recommendations have been put out by NACI, my hope is that the provinces will now adopt coverage for each pregnancy, but that'll take time to trickle down through your province. It's best to check with your province's immunization schedule. Stephanie, thank you. Thank you for being here. Ideally before 32 weeks, but okay later. So yes, it's really going to depend on when the patient delivers. So ideally before 32 weeks to allow sufficient time for antibody production and transfer. Certainly the British data suggested benefit even 7 days before, but the Kaiser Permanente data suggested that there was a diminished efficacy even if it was 15 days before. So you want to allow several weeks for antibody production. I would say ideally a minimum of kind of 4 to 6 weeks. And that's why we aim for earlier in pregnancy in case there's any preterm deliveries. What is the absolute risk reduction for this recommendation? That is a great question, and it really depends on the epidemiology in your region at present. So because pertussis circulates in a cyclic fashion, certainly some years in some regions, the absolute risk reduction is going to be higher than at other times. What about the partner of the mother? Should they be getting vaccinated as well? So certainly NACI guidelines are that every adult should be receiving Tdap at some point in time during adulthood. And I think that when there is a newborn infant on the way, then that's an ideal time for the father or the other partner to be getting their one-time adult booster. Can we do blood work to assess whether a client is already immune? No, because we have no serologic correlate of immunity. So for measles, for instance, or for rubella, we can detect a certain level of antibody and say that above this level of antibody, this person is immune. We don't have that same serologic correlate for pertussis, so there is no antibody level that we can look at and say that somebody is immune. So no blood work can tell us whether they are necessarily immune. Are you aware of any provincial coverage plans for Tdap in pregnancy? Again, this was just released from NACI really in the past 4 to 6 weeks. All the provinces are probably going to be considering the revision from NACI, and it'll depend on each province who's going to cover it for each pregnancy. So look at your provincial guidelines for that. Do you have a number needed to treat for how many people need to be vaccinated in order to prevent 1 case of neonatal pertussis infection? Again, it varies depending on the local epidemiology. So sometimes it will, at some points in time, it will be much higher than at other points, depending on the circulating, depending on where you fall in the cycle of pertussis. The public health nurses in clinics in Victoria, BC are completely unaware of this recommendation and quite confused by women requesting Tdap and are advising them that it's not recommended. The cost in one pharmacy I checked was $48 plus $18 for administration. Any plans to help build the infrastructure? Again, these new recommendations have just been released from NACI. They now need to be translated to the provinces. It's going to be a matter of education and the provinces looking at their provincial vaccine schedules to get the coverage moving for each pregnancy. Is vaccinehealthmap.org Canadian? I'm not getting any results. We will look into that and email you, Kimberly Tigani. Are there any prospective studies for possible adverse effects on mother or child? So there's been a number of observational studies that have included a large number of pregnant women, as well as there's passive surveillance that's ongoing. And there's been no signal of adverse for the infant or for the fetus. Those studies also suggest for the large part that there's no increased adverse events for mothers. There's just that one study that we mentioned that draws on passive surveillance data and found a small increased risk of postpartum hemorrhage to the effect of an odds ratio of 1.1, and for chorionitis neonitis, which found an odds ratio of 1.23. Sorry, I think I've got those numbers mixed up. Postpartum hemorrhage 1.23. Chorionitis is 1.1. So very small increased odds ratios from one source, passive surveillance, and conflicting with previous reports of safety data for the mom. Over hundreds of thousands of doses of Tdap have been administered to pregnant women, and certainly we're not seeing any signals of harm for the mother or the fetus. If someone had pertussis early in life, would this be considered protective, not lifelong immunity? You can become reinfected with pertussis infection. Do we get, yes, CME credits for this webinar? I'm going to let the SOGC handle that one. Grace. What is the rate of mortality in infants with confirmed cases of pertussis? I don't have a specific number. If I draw on our province's data, you're looking at, if you look at hospital admissions from pertussis in very young infants, in Manitoba, we were seeing about 1/3 going to the ICU, about 25% intubated and ventilated for a mean of 6 days. And in a 5-year period in Winnipeg, we didn't have any fatalities, but then the following year we had 1 fatality. So the rate of mortality is not high, but it is there, and certainly morbidity involved with ICU admissions and prolonged intubation are considerable. What is the cost for each dose of the vaccine? Well, somebody posted above what the cost was in BC, about $48 and then $18 for administration. Again, that might vary by province, and coverage will vary by province, but hopefully as the NACI recommendations trickle down and the provinces reevaluate their schedules, we should see coverage for each pregnancy coming through over the next, hopefully, 6 to 18 months. I'm not sure how often the provinces revise their schedules. This might be a question for the larger group, so we'd love to hear from you guys. But what are some of the challenges practitioners have experienced with obtaining this vaccine? So I'm going to wait for maybe some participants to chime in for that one. Certainly we have practitioners in Winnipeg who are in private practice, as well as in hospital-based practice that have been very successful getting Tdap for their patients. Certainly in the hospital, we are ordering it through the hospital pharmacy, and we're administering it in clinic. I know some of our private clinics either are having patients go to the pharmacy or stocking the vaccines themselves and have vaccine fridges within their offices. Do you know, have there been any cases of severe adverse effects from giving this in pregnancy, i.e. serum sickness, Guillain-Barré syndrome, etc.? So that same study that I was referring to above looked at a wide variety of maternal effects, including Guillain-Barré, and they found no increased risk of Guillain-Barré. I don't know if serum sickness was one of the data points that the outcomes that they were looking at, but certainly we're not getting signal of severe maternal adverse effects from this vaccine. Will there be health promotional materials available for expectant patients to make them aware of the need to be vaccinated? And as a prenatal educator, would you recommend this to be routine content that is included? So again, there's going to be a question and answer document that's going to be available on the SOGC website and circulated to you. It is written in a way that it's designed for the healthcare provider, but it's the language is digestible for a patient as well, if you have a well-educated patient. I will have to talk to our communications department about the potential for developing a patient handout if there is interest. And I routinely talk about Tdap in my practice in the visit leading up to their oral glucose challenge test at 26 to 28 weeks, and then I usually offer the vaccine at their OGCT visit date. Are there any asymptomatic carriers for Bordetella pertussis? Yes, that is the source of ongoing infection. Are typically adults who are asymptomatic carriers or have a very atypical presentation. Okay, sorry to beat this question to death. The patient was vaccinated with adult booster of Adacel 6 months before becoming pregnant. Would the recommendation be that she should be revaccinated? Again, we don't have specific data to say yes or no. I can say that it's safe to give based on one observational trial of giving one observational study of having even the vaccine at intervals less than 2 years, and by the time she's in her 3rd trimester, it'll have been about 1 year. She probably does have pertussis antibodies that are circulating in a reasonable level, but I don't think it would be unsafe to give her a repeat dose. Are there plans to present this information to primary care providers so that GPs can help with administering the vaccine during pregnancy? This presentation is going to be available through the SOGC to be shared with colleagues. I understand through the SOGC's YouTube channel. But if you have any specific questions, feel free to email the communications department. For patients who only want pertussis, is there one available on its own, or do you have to get the combo? In Canada, we have 2 pertussis containing vaccines for adults, Adacel and Boostrix, and they both have antigens to diphtheria and tetanus. Could you save them the $18 by having them bring the vaccine to you and administer it at your next visit? Yes, you can. If you feel comfortable administering the vaccine, go for it. Do you know if the available vaccine will be with or without trace amounts of formaldehyde? Both vaccines contain trace amounts of formaldehyde, and I don't know if there's plans for a vaccine that will not have those trace amounts of formaldehyde being developed for pertussis. Okay. So what is the efficacy of the pertussis vaccine? How long does it protect people against it? That came up in the slide looking at the APERT trial. So we see that antibodies start to wane at around the 2-year mark. They start to dip below the undetectable mark anywhere between 2 to 9 years. And we don't have a serologic correlate for immunity, so we don't know exactly what level of antibody provides protection and what antibody level does not provide protection, so we don't know exactly when the drop in the antibody stops having effective protection. Okay, there's 5 minutes left, so I think we'll get through a number of questions, but if I'm not able to get through all of them, we'll email you guys answers. Saskatchewan is providing publicly funded free doses of Tdap for each pregnancy. That's great. That's amazing to hear. Any concerns with co-administration of this vaccine with any other vaccine products, MMR postpartum, with any immunoglobulins? We have no concerns at this point about co-administration with either other vaccines or immunoglobulins. You can give it at the same time as you give them their Winrow or their Rogam. You can give it at the same time as you give the influenza vaccine. MMR postpartum is fine, but again, ideally you'd be giving pertussis in the antepartum period. If they miss it, they can absolutely get it at the same time as they get their MMR postpartum. Is a singular vaccine for pertussis available? I think we've answered that question already. No, we only have Adacel and Boostrix, which both contain diphtheria and tetanus antigens. It is not within the scope of Ontario midwives to practice Tdap, to prescribe Tdap, so it forces us to do a referral to a physician for the vaccine. Again, I appreciate that there's going to be barriers at many levels for rolling out this recommendation for universal vaccination, but we already have the recommendation for universal influenza vaccination. So I think that this is a great time for different groups of providers to start brainstorming about ways to streamline the process in each of your communities. And if in any way we can help you from an advocacy perspective, please feel free to email the SOGC and the Infectious Disease Committee, and we can see what we can do from an advocacy perspective to help streamline things. I have asked patients to see their family physicians for the vaccine and haven't experienced any difficulties with this so far. That's great, Amanda Black. That's a great strategy. Thanks for sharing it with the group. Is it okay to give Tdap and the flu vaccine together? Yes. If the general recommendation is for all people who are in contact with the baby in the home to be vaccinated with Tdap, what does that mean for people who work with newborns, i.e. childcare workers and medical staff? So again, everybody should be getting a one-time adult dose of Tdap. If somebody works with infants and they haven't had that already, they should be getting that. There are, I believe it's just the Northwest Territories, I could be wrong, that offers it once every 10 years as a booster. And in my mind, looking at the results from the APRT trial and some other studies, because of the waning antibodies, perhaps we will see a change in recommendation at some point in time to booster more often, but at this point in time, we're looking at a one-time booster dose that every adult in Canada should be getting. Would the vaccine be recommended depending on the time of year? There's, unlike other infectious diseases, pertussis doesn't follow a seasonal pattern, so we can't predict outbreaks seasonally. I think we're on our last question. Adacel is category C in pregnancy, so that's because their product monograph has not been updated since 2012. Boostrix is category B according to their product monograph. That's because the Boostrix product monograph was updated in 2018. So I agree that this is a problem, that there's conflicting information coming from the Adacel product monograph compared to the NACI guidelines. The Boostrix product monograph is more in line with the NACI guidelines because it's been updated more recently. So I would encourage you to contact the manufacturer and ask them to update their product monograph. I think it would be really helpful. Thank you for noting that. I think we've made it through all the questions. Okay, so thanks everybody for taking part in this. Yeah, have a great afternoon. Happy Wednesday.